respectable guests, dear colleagues and friends, warm good morning, good afternoon to all of you. On behalf of the Capital Medical University, welcome to the second Europe-China Health Summit on Medical Innovation and Medical Technology Transfer. We are now at a special time of facing the COVID-19 pandemic threat. As a healthcare advocate, educator, and scientist, I deeply appreciate the great work sacrifice that the medical colleagues have done across the world. However, to fight the pandemic, we should work together. The idea, solutions, resources, and experiences need to be shared to defeat the virus. That's why we try to connect to each other from Europe to China and to the world by taking this special form of important cross-continental online event, the second Europe-China Health Summit. Through the summit, I hope we could build effective collaboration platforms between China and Europe in the medical technology research and development. We commit ourselves to build a healthier global community, which is the theme of the summit. Taking this opportunity, I would like to introduce our university to you and hope we can engage constructive collaborations. The university has 11 colleges, including School of Basic Medicine, School of Pharmacy, School of Public Health, Nursing School, and School of Biomedical Engineering, etc. In addition, the university has 19 affiliated hospitals with a top number of 20,000 beds and with advanced medical equipment. Most of the hospitals are the top-tier hospital with the highest specialty ranking in China. The university encourages active scientific research and technology development. We currently hold nearly 3,000 research projects funded by the national and municipal sources. With a total of 340 million euros, the university has built international collaborations with partners in the USA, Canada, and Europe countries for joint research and degree studies. By the way, today is our university's 60-year anniversary. We are holding some celebration here in the campus, and the celebrations are enriched by the summit. I appreciate all the hard work of the summit and organizers and committees. Thank you. I'm pleased that the School of Biomedical Engineering can be the co-host of the summit. The theme tracks of the summit are closely related to the BME specialty directions of bioinstrumentation, biomechanics and rehabilitation, medical informatics, and the clinical engineering. Finally, I wish the summit achieve a great success. Thanks.
So I will introduce you Orphanet, but before doing that, the challenges of rare diseases. So rare diseases are those that concerns few people at the same time, so low prevalence diseases, and they are highly variable from one disease to another, but they all share the challenges due to their rarity. So rarity poses challenges because they are so numerous that any doctor can know them all. So the first challenge is giving a name to the patient or having a rare disease, so posing a diagnosis, and then helping patients navigate the healthcare system to reach the right experts, because rare diseases are rare, but experts are rare as well. And providing information to doctors on best practices to take care of their patients. But it poses public health problems because we don't know exactly how many patients are there, how what is their use of healthcare systems, in order to commission health services appropriately and to focus service delivery on specific patient needs, and that is particularly needed in emergency situations. And then for research, identifying patients, it's going alone. Identifying patients for clinical research, sharing data across databases, registries, repositories, and electronic health record. That is a crucial step in rare disease research. And then planning clinical trials and identifying the markets in order to negotiate the prices for orphan drugs, so medications for rare diseases. So what are rare diseases? We don't have a single universal definition, for, for rare diseases, but all the definitions are based on in prevalence. Prevalence is the number of patients at the same time in a given population. So you see that there are huge differences between the definitions, and we adopt the European definition that is less than 50 patients for 100,000 inhabitants. The consequence of that is that all the countries, all the regions in the world share a largely overlapping list of diseases. But as you will see in the next slide, they cover a very different population of rare disease patients. How many rare diseases are out there? So to count rare diseases, we need to adopt a common definition. At Orphanet, we have adopted a clinical definition of rare diseases that is represented here by the orange dots. And based on this clinical definition, there are around 6,000, or between 6,000 and 7,000 rare diseases. You need to know that it's a very evolving field in which new diseases are discovered all the time. So we published an epidemiological study based on the data on prevalence, on point prevalence that we have in the Orphanet database, in order to know better what are these rare diseases. So strikingly, most of rare diseases are pediatric. So up to 88% of rare diseases affects exclusively or can affect children. 1/3 are not genetic in origin, and the vast majority are prevalent diseases, so chronic diseases, but we have 14% of rare diseases that are incident, so including rare cancers, rare infectious diseases, are diseases due to toxic effects. And to answer the question of how many patients suffering from a rare disease are over the world, in that study, based on the Orphanet database on epidemiological data, based on literature, we calculate what we consider the best minimum estimate of the global prevalence, that is between 3.5 and 6, let's say, of the population, a percent of the population, so up to more than 400 million people worldwide. But strikingly, we saw that the vast majority of the people suffering from a rare disease have one of the most 390 most prevalent diseases, and 2% of the patients share 90% of the diseases. So most rare diseases concern a very few number of people. That is extremely important because those are the most vulnerable amongst the vulnerable. So because of all these challenges, Orphanet exists since more than 20 years ago with 3 main missions. The first one is to improve the visibility of rare disease by providing a common language and nomenclature across sectors, healthcare and research, but also across countries, because this nomenclature is in several languages. And that are the ORFA codes. I will introduce them more in detail later on. Provide high quality information and also information on where experts are and services are on rare diseases, and contribute to the generation of knowledge by putting together all the data about rare diseases in a knowledge base that is centered in the nomenclature, that is aligned with other nomenclatures for interoperability, and that is annotated with phenotypes, with disability facts, with genetic genes that are related with rare disease, epidemiological data, information, textual information, the information on medications, orphan designations and drugs, and a directory of expert resources for rare diseases in the countries of the Orphanet network that you can see here. So the dark blue are full members and yellow ones are contact points. So based on this Orphanet knowledge base, there are several products, if I may talk like this. The most, let's say, famous one is the Orphanet website, that is the information website, orpha.net, that is a multilingual website in which people can have the information disease by disease. But then we have a data download platform that is orphadata.org, in which you have free data sets and on the scientific information of rare diseases, and some data sets available on request on the textual information and expert resources. And the free part of Orphanet has been labeled Elixir Core Data Resource, that is a label in Europe that recognize conceptual authorities in different domains. And then we have the ontologies, the Orphanet Rare Disease Ontology, and an ontological module that connects by urban associations the HPO ontology, that is a human phenotype ontology produced by the, that is translated in Chinese, by the way, that is produced by the Jackson Institute in the US, and the Orphanet ontology. So here you have the detail of the kind of data you can have and the formats in which it is available. And of course, it is also documentation and tutorials are also available. So now let me introduce the nomenclature, so the ORFA codes, but that is, I think, most important in this meeting. So as far as in 2009, in the Council recommendation on action in the field of rare disease by the European Commission, improved codification of rare disease was set as a priority. Why? Because there is no medical terminology that include all rare diseases, and even if when rare diseases are included, they are mixed up amongst non-rare diseases. So there is no way to know, to differentiate the rare from the non-rare, and to make aggregated data based on rarity for exploitation purposes. So that's why we fill this gap, producing the only specific nomenclature on rare diseases, with around 6,000 rare disorders, but more than 10,000 concepts, in which there is a unique identifier, the ORFA code, that is noted ORFA, 2 points and the number, that is specific for rare diseases, and that is never reused. So the code is stable over the time. The nomenclature has a preferred term, synonyms, a definition, and several metadata. And it is translated in 9 languages, and ongoing, the new translations are ongoing in Japanese, in Russian, in Turkish, and in Chinese. The nomenclature sticks to the European definition, so less than 2 cases I'm sorry, less than 1 cases in 2,000 inhabitants, and a disease is created with there are at minimum 2 individual cases. The nomenclature follows a logical structure, so the 6,000, as I said, follow the clinical definition. Why this definition? Because it is the most comprehensive one that is really covering all rare disease, so genetic and non-genetic diseases that for which the cause is known or unknown, because the clinical definition describes what the patient has and what the doctor sees, and that is the most universal one. But of course, each disease can be subdivided into subtypes, for instance, genetic subtypes, and grouped into clinical groups or categories that allows for the organization of the nomenclature. The classification of rare diseases in ORPHANET is multi-hierarchical because most of the rare diseases are multisystemic diseases and can be so multi-classified inside the same classification. And each classification follows a medical specialty. So you have rare cardiac diseases, rare neurological diseases, and so on and so forth. But when it comes to make statistical analysis, you need to count the disease only once. And that's why we produce a linearization for statistical purposes in which diseases are classified in their preferential classification. And for that, we set up a number of rules to do that in coherence. This nomenclature is, we call that the interoperability backbone for rare diseases. Why? Because the nomenclature is connected, so mapped through semantic relationships to other medical terminologies, but also through semantic relationships to other pieces of data, like functional consequences or disabilities related to rare diseases, orphan drugs, phenotypes using HPO, and the genes with a kind of relationship between the gene and the disease. And genes are also connected to other external resources, completing the genetic information. And the ORPHANET nomenclature is used in the healthcare setting because it is a recommendation of the European Commission, and in the research setting in registries, cohorts, and biobanks. You can find ORPHA codes, of course, in the ORPHANET website. We produce a PDF because it is a useful format for coders once a year. The whole nomenclature is downloadable in ORPHA data, and that files are updated every month. And then we have a specific pack for the codification in countries in which the recommendation that was set up by the RD Action is that the nomenclature is released once a year in July. And of course, the ontology of rare diseases. Then we have a GitHub in which you can have the monthly versions of the nomenclature with the differentials, and a series of other formats like the ORPHA packets, in which you have for each ORPHA code all the data that is related to that. So the nomenclature data, the epidemiology, the parents and child in the classification, genes, HPO. So it's an exchange format similar to the phenopacket that is produced by HPO for phenotypes, and that is in a computable format in JSON on YAML, and of course, tracking changes. So we provide files and tools for integration, the ontologies with a SparkQL endpoint. You can download in ORPHA data, but also in BioPortal, and in the ontologies look at service of the EBI. And we are setting APIs on the band and a specific API for codification in the RD code website, together with guidelines, guidance and support, a help desk, and trainings that are being prepared that will be delivered in local language by Orphanet national hubs. So ORFA codes are key for semantic interoperability because it provides a common language between countries, between sectors, and it is updated, so follow up the evolved knowledge on rare diseases that is very dynamic, allowing for aggregation by rare diseases groupings specific for rare diseases, allows for the isolation of rare diseases from common diseases, and maintaining interoperability between health and research that are using different terminologies. And it is a foundational part of a global interoperability ecosystem in Europe, setting the research data and resources infrastructure. So we need to make this more than 300,000 million patients worldwide count. So rare diseases data sets should be present in electronic health records across countries in order to exchange data in a standard exchange format, data exchange format. We want to have the ORFA codes present in the electronic patient summaries for unplanned care, because it's where the patients are the most vulnerable in their lives. And also, we need to have standard exchange formats to be set up to allow healthcare data, including patient consent, to be exported for secondary use. And for rare diseases, that should include the ORFA code, but also a minimum set of data that are necessary for evidence policymaking, research, and a better care. I thank you very much and I leave you with this excellent sentence from a friend of mine, saying that if we cannot count rare disease patients, they do not count. Thank you very much.
Good morning or good afternoon, everyone. I'm Jingdong Li from HL7 China. My report is HL7 in China. I will cover 4 items: HL7 and HL7 China introduction, interoperability and the needs of healthcare information standard, HL7 China standard development, education, and conformance testing, the current ongoing work and challenges. HL7 International was founded in 1987. It is a not-for-profit organization dedicated to providing a comprehensive framework and related standards for the exchange, integration, sharing, and retrieval of electronic health information. Since 1987, HL7 International has developed a long list of standards. So I put these primary standards in this slide. You can see the CCDA. The CDA is a clinical document architecture. It's a standard for the electronic clinical document exchange. The CDA release 2, the FAIR release 4. FAIR it means the HL7 Fast Healthcare Interoperability Resources. It's an abbreviation of Fast Healthcare Interoperability Resources. And HL7 Context Management Specification, CCAL. HL7 version 2. HL7 version 2, we also call it the messaging standard. So HL7 version 3, so it's also referred to the RIM standard, Reference Information Model standard. So among these primary standards, the CGA Release 2, FAIR Release 4, and HL7 version 2 are the most used standard in China. HL7 China is an affiliated organization of HL7 International. It was founded in 2006. So now it is 14 years old. HL7 China's activities mainly in 3 areas. They are standard education, standard development, and standard testing. So the standard education takes upon at least 60% of HL7 China's activity because of China has a big shortage of HL7 standard professionals. So the next slide, I will briefly talk about interoperability and the needs of healthcare information standard. What is the interoperability? Interoperability means the ability of health information systems to exchange, share, and understand each other's data to advance to better healthcare services. So today we are in data age. Hospitals and public health agencies have accumulated huge amount of data. We wish we can unlock this data, use the data to achieve better healthcare outcome. By sharing the data among different public health agencies, we are able to early detect disease outbreak event. By sharing the data among different hospitals, we can avoid redundant medical exam, such as lab tests or radiology examinations, to lower healthcare cost. But the reality is that when we deal with the healthcare data, we often find the data quality is not good. Sometimes it's bad. Because there's no data standard in position, the data for same information from different hospitals and organizations are often very much different in terms of format, granularity, and wording. So these are big barriers preventing us from effectively using and sharing healthcare data. To overcome the barrier, I believe the right answer is standard, is HL7 standard. So if you look at the lower left corner, the diagram, if 8 hospitals would like to share data among them without having data standard, each hospital has to develop 7 different data exchange interfaces in order to exchange data with the other hospital. So it's a big burden. But with HL7 standard, each hospital only need to develop 1 data exchange interface. And that interface will send out the standardized data, will receive and process the standardized data sent by other hospitals. So that's a dramatic reduction of development time and implementation effort. Another example is the upper right corner. So HL7 standard not only defines the data exchange format, it also defines the semantic model, clinical concept semantic model. So this is the model defined by FAIR. This is the medication model. So this model contains all the information pieces, or it contains all the child data elements regarding a medication, such as medication, the drug name, the frequency, the start time and end time of drug usage, and the dosage, the route, manufacturer, ingredient, so on and so forth. So based upon this model, different organizations can develop very same medication data stream. And that will significantly improve the data quality when this data is shared among different organizations. So by adopting HL7 standard, you can see the data exchange is much easier, and the data quality will be improved significantly. And finally, we can achieve the goal of unlock the data, fully utilize the data, and to get the maximum data value to support different clinical healthcare scenarios. Next, I will talk about HL7 China standard development, education, and conformance testing activities that we have done in past years. Standard training. China has a big shortage of HL7 professionals. In order to cultivate HL7 China community and HL7 professionals, we have a biannual CDA education event. We have a biannual V2 message education event. We have a biannual FIRE education event. So this event normally one is held in the northern China, another one is held in the southern China. So for the people to participate more conveniently. We also encourage the HL7 China's member to take HL7 international certification, such as the CDA certification, FAIR certification, V2, and V3 certification. The HL7 members certified in different standards are published in the HL7 China's website. So these pictures are taken from the different education sessions. You can see. Standard development. HL7 China did a survey, then found out there are demands for sharing clinical document between hospitals. And patient also has have demands to have the clinical document in hand. So after they went to big city to see the doctor and back to hometown, they can present the provide the clinical report to the physician in their hometown. HL7 China has developed a list of CDA IG. The implementation guide includes inpatient medication record summary, adult physical exam report, inpatient discharge summary, outpatient clinical visit summary, and a lab report. So we have used the Lantana Trefolia tool to develop and publish the CDIG. All the IG was available publicly, and it's they can be downloaded from the HL7 China's wiki page. So here down below is the entry template of CDA inpatient medical record summary IG. So you can see it's structured, it specified the code, the relationship, the cardinality of the discharge medication entry. Standard testing since 2018, HL7 China has held Fair Connectathon annually. So there are many China HIT vendors participate the Fair Connectathon to test their interface, to test their level of conformance to FAIR standard. So the current testing scenarios covers the patient appointment, surgery, medication, as well as terminology. These are FAIR resources. The tested scenario include creation resource, update resource, retrieve resource, and delete resource. So here's the pictures that was taken from the CHIMA conference, the testing, the Connectathon testing room. Next, I will talk about the current ongoing work and challenges. Ongoing work. We plan to develop FAIR resources in China realm. The first batch of FAIR resources are essential data elements in healthcare settings, such as patient, provider, encounter, diagnosis, lab observation, medications, so vital signs, etc. We are developing a FAIR testing server so to support the near future FAIR standard conformance testing. And we have made pretty good progress. Hopefully in October, we can have this testing server up and running. We plan to develop FAIR implementation guide. Also, you can call it FAIR profile in China realm. The implementation guide will be in certain disease domains, such as cardiovascular disease or neurology disease. Besides this ongoing work, we will still perform the regular activities such as standard training and fair connector zone testing. Challenges. HL7 China, as a not-for-profit organization, faces some challenges. Challenge one is all the members are volunteers. All the work was done voluntarily. Because all the members are volunteers, sometimes a project was set up. It is difficult to advance according to the schedule. And because of the volunteer-based, sometimes it's hard to maintain a stable workforce for continuously IG development. So another challenge is the shortage of HL7 professionals. China still have a big shortage of HL7 professionals. So HL7 China will do more training, more education session to overcome this shortage. Currently, HL7 China community members are mainly from HIT vendor. Most of the members are software engineers. There are only few members from healthcare settings. So we need to bring more healthcare professionals into HL7 community in order to produce the implementable, the meaningful, the problem-solving implementation guide and standard. So that's another barrier, another challenge that we need to overcome. This brings to the end of my report. Thank you very much for listening to my report, and welcome to join HL7 China. Here's the HL7 China's website, as well as my email contact. By the way, this is my first time to do the recording meeting. I'm not used to it, so I apologize if there's any inconvenience to you. Thank you very much. Bye-bye.
Thank you, and good morning or good afternoon. Thank you for inviting me to have a talk on the way that HL7 has been used in introducing large-scale COVID-19 testing in the Netherlands. But before I go into the details of that, please let me introduce myself. My name is Robert Stegway. You can see all my credentials here. What's the first case of... I'm sorry, I'm getting the pre-recorded version anyway, so I have a little problem making sure that we get this. Let me see how I do this. I'll just go through the slides this way, because in presentation mode it won't work, because then it starts to replay what I recorded. Can you see it now?
Yes.
It's still sharing? Yes. Oh, it's paused. There we are. Okay. Sorry about that. You already gave quite an overview of what I've done. I'd like to focus on what I've done recently. In the last 4 years, I've been contracted by the Center for Infectious Disease Control to set up a project about lab information, and specifically around the reporting, national reporting of lab tests for antibiotics resistance. And that's where we gathered a lot of experience in the use of standards for large-scale lab reporting. So in April 2020, I started there, and I will tell you a little bit about how the corona pandemic unfolded in the Netherlands. We had our first case in February. 1 week later, we already had our first death. And that's when regional measures kicked in just in 1 or 2 provinces. But only a couple of days later, it was clear that something needed to be done at a national level. And even on mid-March, we went into what was called an intelligent lockdown. Not a total lockdown like other places in the world have experienced, but still fairly severe measures. It also meant that we needed a strategy to come out of the lockdown, and that strategy was presented to the Parliament on April 7th. It had 3 pillars, basically: test, track, and report. And it also included work on 2 apps, especially around the tracking and reporting. But as mentioned, I was called upon to help with the testing. What does that mean, testing? Testing, large-scale testing, especially in the public health environment, is a public health responsibility. And in the Netherlands, we have 25 regional centers for public health. And from an IT perspective, you can look at what kind of systems are they using for infectious disease control. 23 have the same brand of system, but 2 had a different system. But that doesn't mean that it all worked in the same way. And on the other hand, the Center for Public Health, except for 1, don't have their own labs. So they have to contract with outside labs to actually carry out the COVID-19 testing. And we had, at that time, 62 accredited labs for COVID-19 testing, including 8 what we call pandemic labs. Those are labs that are not regularly doing the patient diagnostic services, but are, for instance, veterinary labs or blood transfusion labs that also have capacity to support COVID-19 testing. So that's what we were facing with. I'll share with you a few observations on what has been going on. I already hinted at it. Each regional center for public health has their own way of working, which may be very sophisticated, but also often it's paper-based, and it actually meant manually rekeying test results. Even though they were delivered in an electronic format, there was no interface to their system to actually accept those test results into their system. And for infectious diseases, that's not really a problem usually, because it works fairly well. If you have 500 tests per day, which was the average before the outbreak, and 2,000 tests was a bit of a stretch, but it still could be done in early April. But we were aiming, or the National Center for Disease Control actually looked at 30,000 to 70,000 tests per day. That was their scenario, and that surely cannot be done by all kinds of manual entries, etc. So the choice was made as part of the strategy to make testing available to the larger population, everyone with mild symptoms, and that's what triggered the development of a new system. So that's the strategy that we worked on. And we pitched that strategy on April 6th, just a day before the overall strategy was pitched to or presented to the national government, or the national parliament, I should say. And it actually meant we need a new system. We cannot work with those 25 individual systems within the public health center. We need one system for all public health centers so that we have one hub from which to actually organize the testing. It does the registration of the people that want to be tested. It does the triage. Do they have mild symptoms? What symptoms do they have? Scheduling to one of the test facilities that are operated by the public health centers, where the swab will take place, and finally the system will, after of course sending the specimen to the lab and getting the results back, it will support in reporting those results back to the patient or the person that actually went through the test. And only when it's positive, then the patient is handed over to the existing system for source and contact tracing, so that we actually know where the people got the infection. In the beginning, we had 8 pandemic labs, as mentioned, 27 contracted labs, and we also envisioned a phase 2 after the June 1st go live moment, when people were actually being tested on a large scale. We foresaw a phase 2 with another 19 labs to help get to that number of 30,000 to 70,000 tests per day. So that's the strategy that we pitched, and on April 8th, we actually got the go-ahead and the funding to start doing this. So what's the challenge that we have? It's basically an interoperability challenge. At least my perspective was the interoperability challenge between the new system for registering and administering the tests and the labs that had to carry out the test. You have to have one HL7 message to order a test, and one HL7 message to report the test result. You need to agree upon the code to use, in our case, a LOIN code to identify the test. The MIMTT codes to identify the sample, the LOIN codes to identify the test result, etc., etc. So there's a lot going on, and also just simple things as a barcode. We had to invent a barcode for the samples. And we came up with this one, identifying the lab, one of the 35 labs that were in operation in the first phase, with 3 digits, and the rest is just the code for the sample. But you need to agree upon all these things. So that's what we really needed to do in a very short term, and also roll out the secure network for ordering the tests and getting the results back, connected to all the different labs, and we had to do that within basically a month and a half. That's quite a challenge, I can tell you. But if we go to the next page, we actually, in the first week, starting June 1st, we carried out 50,000 tests. So that was not bad. It was well over the 2,000 tests that we're doing on a daily basis. So the system worked, and we did get feedback from the labs that this would not have been possible with the current system, with the old system, and the old way of working. So that was quite successful. And of course, the question is then, how did we achieve this success? Basically, it's because we already had invested in the HL7 standards, and that's where I mentioned my previous work with antibiotic resistance. We actually had agreed upon, as a community, that these are the HL7 standards that we need. This is the national lab code set that we want, which is a coordinated subset of LOINC and SNOMED. Because if you look up SARS, or you look up any specific test within LOINC, you will find a number of possibilities, and you need to have a group, a dedicated team that really coordinates how to use LOINC and SNOMED within your country to achieve a true interoperability. And this team is consisting of medical microbiologists, and also some of the application management professionals that are responsible for the laboratory information management system. So we had already worked on the antibiotics resistance with most of the labs and the vendors of their laboratory information management system. So there was a community out there that we could call upon. In all, about 100, 150 people across the country were actually working on this, and we had easy contact with them. But of course, most importantly, the urgency was there. We have been working for 4 years on the antibiotics resistance, and we did get 20 labs to sign up, but only 5 labs to go live. And now within 1.5 months, we had to get 35 labs live. So, and we succeeded because everybody understood that this needed to be done in order to facilitate the large-scale testing across the country. And that really made the difference. Of course, urgency also means that there's no discussion on finances, and people will pitch in terms of finances from the ministry whenever there is a hurdle. So this is really what we did, and how a common investment and community building around the standards really helped us to achieve this. Of course, the question is, where are we now? We actually introduced a phase 3. We did get the other 19 labs on phase 2 live in the course of August. But also in the course of August, we already saw a rise in the number of tests and the number of positive tests. So we had to engage more labs, and we had to go outside the Netherlands to actually contract labs and connect them in the same way. And basically last week, we had over 300,000 tests. So we went from 50,000 in the first week to over 300,000 last week. And we have almost 3 million tests running. Just for comparison, we're a relatively small country. We have 17 million people, so we're basically the size of greater New York City, and that's all of our country. But still, we managed to organize our healthcare system in such a way that we need 62 independent different labs to actually do this, and extra labs outside the Netherlands to help this. Given the pressure on the large-scale testing, priority groups have been identified, and we are also looking into new tests being implemented, including a breath test, which has a very good result on the negative side. So if the breath test says you're negative, then it's sure that you are negative, so we can eliminate a whole group of people going through the PCR testing. That's the gold standard for SARS-CoV-2 testing. And it helps to have the HL7 infrastructure in there, because you can just easily point at what needs to be changed in the interface to have this new test implemented. Also supported again by the active community and by this dedicated group of professionals that is managing the terminology that we're using. So that's my talk for today. If you have any questions on what we've done, or just drop me an email later, but I'm happy to answer any questions right now.